Hi, and welcome back to the Trusted Messenger podcast. I am your co-host, Trusted Messenger Program VP of Comms and Strategy, Chad Herman, along with your other co-host,
Todd, Executive Director.
This is an exciting episode for us for a couple of reasons. Number one, this is dropping, as the cool kids say, officially airing on December 26th. So it's kind of our home for the holidays episode. And who better, and I do mean who better to have as our guest on the home for the holidays episode than someone who is, and I'm going to date all three of us and probably at least some of our listeners by saying, he is the Robert Klein to our collective Johnny Carson. He is the guest. I knew I could count on you for that music.
Well done, Tom.
He has been a guest of ours on the late lamented Kids Plus podcast and on the late great Kids Plus live stream more than anyone else. So it's fitting that we get him in early, and something tells me often here on the Trusted Messenger podcast. Who are we talking about? That guy right down there at the bottom of the screen. His name is Dr. Andy Nowalk. He's Clinical Director of the Division of Infectious Diseases at UPMC, Children's Hospital of Pittsburgh. That's right here in Pittsburgh. And because you can't do just one thing these days, he's also, and we will talk about this in the episode, an Associate Professor of Pediatrics at the University of Pittsburgh School of Medicine. Andy Nowalk, our friend, our colleague, our partner in D&D and horror movie crime.
Wow.
Welcome to the Trusted
Thank
Messenger
you so much.
podcast.
I feel I'm like the ghost of Christmas present in that I'm loud, I bring joy, and I guess I'll disappear at the end of the podcast. I'm not sure. And maybe we'll learn a lesson. Just like Dickens wanted. So, God bless us, everyone.
If you two start throwing literary and movie references around, I'm like barely holding on right now, so don't start going over my head.
I think it's too late. He already did.
Todd, the Muppets made a version of the Christmas Carol. Come on. Come on.
I will say, Dr. Andy Nowalk, you are back. You are back, my friend, because you are not just a pediatrician.
I am
you
not.
are not just an infectious disease specialist. You are not just an educator and teacher. You are, my friend, an outstanding communicator.
Well, thank you. I tell our residents all the time, communication is a muscle, and you can tone it and you can exercise it, and you can always learn new things that are going to make you better. And so I've benefited from you guys. Among many others in terms of learning over time. And Todd, in the way past, I've learned from people like my good friend Dina Hofkosh, who was a legendary person in my life, but Scott Maurer and a ton of people who've made me a better communicator over the years. So I stand
along those lines, though. You named great communicators that you came in contact personally with. Was it ever anywhere along the path of your medical school residency or professional path part of your curriculum or required learning?
Very rarely. I will say that one of the reasons I mentioned Dina is her innovation when I was a resident, these many years ago in the late 90s, that we had a course called a communication course. And I was like, what the heck is this? It was a course that would teach you using simulation and simple techniques on how to communicate effectively with patients and parents. That's still not as common in medical education as anyone would like. And, I think in the end, too, one of my points of view on communication is very simple, that families have trouble seeing competence, right? And I think that we all appear competent. We have training, we have letters after our name, we have nice office buildings, et cetera, et cetera. So I think that can be hard for them to sometimes assess, like, is this the most competent doctor they've got? But you all know, you've been in a doctor's office, right? You can tell in 30 seconds who's a competent communicator immediately, because we can recognize that immediately. And if you don't bring the communication, the competence is, who cares? If you can't communicate, then the competence is irrelevant because you'll never get the message across.
Spot on. Competence and communication, right? Knowing who's a good communicator, easy to detect. It's something that we are now finding out through interviews we're doing across the country now, Andy, of healthcare providers who are just literally telling us they're on the back of their heels when they're walking into the exam room. I mean, vaccines obviously keeps coming up as a top issue because it's just such a 1,000-degree topic, it feels like right now. But it's other things too. It could be antibiotics, or it could be just follow-up visits. It could be anything where we're trying to communicate the importance of something to a parent. And parents are also coming in saying, I don't know what to believe anymore. So communication's never been more important. But as you pointed out, other than a fellow colleague that made it a key part of their curriculum, not even now. I think I know you've done some work with students on this, but can you talk more about it?
Yeah, I think that as part of our approach to medicine, the School of Medicine here is doing more, which is great. But what we have really targeted is some of those opportunities for vaccines and communication, which have been, really more and more important over the last few years. So we've targeted that at a bunch of different levels in the School of Medicine. And what we've tried to do is to use the framing of vaccine education, which is the thing ultimately that I'm most passionate about, and kind of combines my educator hat and my infectious disease hat, and trying to talk through that, those strategies and the best practices for that with students and residents and train them up. Because it is complicated out there. And, one of the things that I feel for families and for patients, I said it's hard to see competence. And so you got a lot of folks out there projecting that they're really competent who are selling things, right? And are bad players in this environment. So we're going to have to be even better at that communication. So I've been focused on this probably for about, 7 or 8 years that I've done courses at the School of Medicine to really emphasize the changing vaccine environment and changing society, with patients coming in armed with a lot of information that they've pulled in, and then being able to deal with that live, and then using some really well-grounded techniques. So the need for this is really a big one.
I know
And just to be clear, Andy, when you talked about people selling things, you're not talking about used cars. You're talking about, which is a great movie, by the way, Kurt Russell, Bob Zemeckis, amazing movie.
Come
exactly. But you're not talking about used cars. Of course, you're talking about, essential oils and healing crystals and nutritional supplements that are approved by literally no one with a degree in anything. Right.
Yeah. Or, I think this is the linkage when you really, you guys have done so much amazing work about the anti-vaccine movement. The linkage between the anti-vaccine movement and the natural products movement, or selling something, is very strong, because I think a lot of parents don't recognize that the next phrase after vaccines are dangerous, don't take them, is very frequently, you should take this. And by the way, it is $9.95, a special right now on my website.
That's true. Act now.
Act now. Yeah.
So obviously, Todd and I, the work that we're doing here at TMP is very much about empowering healthcare providers to be better communicators so that they can handle patients and caregivers of those patients. You talk about talking with your residents, teaching them about communication. What's their response when you say, hey, we're going to spend time talking about how to talk to people, which we're guessing by the time they get to you, they've not really heard much of that in their training. That does seem to be, that's what we want. We want them to hear more of that. When you're broaching that subject and teaching them, what's their reaction?
When I phrase that I am going to help you be better at a difficult conversation, they like that a lot. And I think that's really what I'm talking about, is that routinely getting very, very strong muscles about doing that conversation work on a routine basis in those rooms where they might feel uncomfortable. And I think that they're very open to that. Like I said, I think there is a little more training than there was before, but what we're really trying to do is have them shovel ready and ready to, get the job done for the challenging conversations along the way. It just turns out that some of the principles that you're teaching and some of the things that we do help you with all communication in all of those clinical realms. And then what I'll also help them understand is that it's not just going to help them in the room with the patient, it's going to help them be a better part of the team for their colleague. And so they're just going to be more effective because we are playing a team sport in healthcare. There's nobody who's doing it by yourself. And so effective communication in the room is great. And then when you get the side benefit of effective communication with a colleague helps you get the job done in your group, that's really wonderful. And so we really try to stress that they're going to get several levels of benefit here. Sometimes they've heard a little bit of it before, but often not put together in the way that we put it together.
Yeah, I'd be interested to see, like, so you're doing this at the medical school. Is there anything comparable at the residency level that you're aware of, either in your residency at your institution or at other residencies? Because we've really been scratching our heads to try and come up with communication being a part of a resident program anywhere.
Yeah, I mean, I don't know the whole landscape probably as well as I should, but I shouted out Dina Hofkosh, who started it, but I'll also highlight the work done by Evelyn Reese in particular and Sylvia Choi here for the communication course for our residency program. And, it's a course that has morphed and changed over the years to meet the needs of the learners, which is what good education does. And it really focuses on different levels of communication challenge for different levels of resident. And we try to pick the hardest problems. Our communication course here practices for our interns, practicing an unexpected diagnosis of Down syndrome, which is a really heavy conversation. And then the second year's practice when a parent or family member or patient expresses significant bias about something about the provider, which is a really hard thing to think about keeping your feet on in the room. And then the third one is revealing a major error. And Todd, you are well familiar with that. I mean, there's a good bit written about that, but the opportunity to practice error, disclosure is not frequent. And so we try to use some simple tools that are out there. The NURSE Mnemonic has been around for a long time, and we use that very, very frequently to help work through these things. And we change the challenges along the time, and then we'll come back to it with some smaller modules. We do some stuff with our second years around a critically ill or dying patient and how you have conversations with the family around that. We do some work with our third years specifically about how they're leading teams and how they can communicate well across multi-generational teams as well. So, we try to have it be a comprehensive program. I think we're a little unusual in how often we're coming back to it and how organized and also how long. I think this is really one of the longest lived residency communication education strategies that there is in the country.
I'm actually thrilled to hear that. Yeah, I mean, that's first off, I do want to clarify the reason Andy's saying that I would know about errors and the literature there is not because I was an error-prone pediatrician. To be clear,
why would you think I'm saying that?
We could analyze the diction and the syntax and the pattern that it came out, but it was pretty clearly there because I was going to jump in and say, for those folks out there who are watching and don't have a lot of familiarity with Todd, we need to make sure he really was not an error-prone clinician.
He was certified for a long time. I mean, come on.
I was going to tell you that your camera's cutting off the top of your head a little bit, but now I don't even want to tell you. Now I'm going to let you just suffer.
I'm going to slink down in my chair now that I've accused you of terrible.
Well, I didn't, look, I'm just talking framing at this point.
Andy, let's go back to something that you just talked about.
Sure.
I'm particularly interested in the that series of prepping the residents to have difficult conversations. As someone who taught that as part of an academic curriculum, that's a really interesting and specialized stuff. So can you give us a 2 or 3 minute summary of some of the things that you do with students to help them prep, or those residents to help them prep with difficult conversations?
I think that we start with some things that have fair amount of evidence behind them that they never think of, which is just positioning. There's actually pretty good data that when a physician sits down, that the family's perception of the length of the conversation and the amount of information provided goes up, even if the exact same content is provided standing versus sitting. It turns out that human beings don't like it when people loom over them. And yet we forget that a lot. And so we just say, first of all, sit down, after obviously you've introduced yourself in your role. And I think even in a primary care setting, one of the things that we joke about is those white coats that we never wear anymore were a little bit helpful for a family to identify, who are you? What role do you play in my child's care? And Todd, even in the office setting, I think, there can be a lot of blurring of like who's who. And pediatrics, people will often automatically assign gender roles incorrectly in our hospital setting.
Yes.
And so we really want to have folks clarify, I am here because this is my name and I am here as part of the team. And be respectful in that intro piece, sitting down to say, simple things like, how do you want to be called? My wife, for example, and she may be mad that I mentioned this, is not a huge fan of like people coming in and calling her mom. She'd like to be called by her given name. And when I started asking about that, spurred by my wife, turns out a lot of people do.
There was a doc in our practice, that I can think of that, would oftentimes refer mom and dad. Some people loved it, but some people did not, I bet, right? So
yeah. And then I think a lot of what we focus on after those really simple interventions that get you off on the right foot. And really, the sit down, the appropriate introduction, so people know exactly who you are and why you're there. We focus a lot on, delivering news and then just listening. And when we say listening, it's just listening for understanding and listening for emotion. And that podcast listeners may be like, wow, that's dramatic. They've learned to listen. But I think it's listening intently with a purpose to really hear how news lands and to the emotion it elicits and the degree of understanding that may come with it. Because once there's an emotion out there, which often happens in these settings, and that emotion can be confusion or it could be anger, it's really flipping into what we call our NURSE Mnemonic, which is to name that emotion. I say this all the time, which is, boy, that news really seemed like it threw you for a loop. Or, wow, something I said really seemed to make you angry. And then, understanding that, which is which is to very simply say, boy, I know that was a lot to hear. That diagnosis I shared with you, or that new lab result that changes the path of it. And then, I think really, responding to the patient that's in front of you and really responding to them appropriately when they're coming back at you and giving them, an appropriate response to meet them where they are. Do they need more information? Do they need silence? Do they need comfort? And then always saying, I'm here to support you. One of the most common things I say in hard vaccine conversations is, we're actually on the same page. I want your child to be healthy, and so do you. So let me help you, support you in that with some of the expertise I can bring, and then exploring these things after that.
Andy, can you just, the NURSE Mnemonic you've referenced 2 times, just letter it out and just say it
again?
You want
to name that emotion that you see in front of them, or name that what you're seeing, measure that time. You want to be clear that you understand that that's appropriate. You're going to let them have that emotion. You're going to say, hey, I can understand that this news could be a lot for you. And then really to respond specifically what you see. Your next piece should be, if it's a lot of anger, that's the wrong time to respond with, let me give you a lot of statistics all of a sudden. That may be the time to let the parent speak and really give them the space to go. The support piece, which is the S, is really about just being clear about supporting it. When someone has a big emotion and you can say, I support you in that, even if you may be a difficult conversation, that can be a game changer for a parent. And then the E is for explore. And that for me is really the most fun part, because then that gets me to say, wow, that really seemed to throw you. What about what I said really was just so devastating in that moment? Was there something that I said that I could explain more? And so the naming, the understanding, the responding, and then supporting and exploring is the NURSE Mnemonic. And it's just, there are other ways to do that. That's just one, but it's the one we've used for so many years that sadly my kids know it as well, because it works in all manner of life. But I'm a leader of a big program. I'm the residency program director here as well. And so much of the time when I am working with teammates, what I will say is, we just proposed to do this thing for reorganizing the block schedule. And man, you look like you're going to kill me. You look really mad about that. Clearly something I said set you off, which is being understanding and supportive, and then saying, so, what happened there? Let's just stop. And I don't want to go any further before I figure out why I'm behind with you. And so that's each of the pieces of that. It's just a wonderful tool along the way.
Andy, I want to go back to a phrase that you used, and actually another reason why you're the perfect guest. You gave me the absolute ideal segue because I wanted to go precisely here anyway. You talked about meeting people where they are.
Yeah.
And that's a phrase that, of course, we hear a hell of a lot in healthcare because it's good advice. But Todd was just telling me about an hour before we recorded this that he just spoke to someone who works in healthcare who said, we talk a lot about meeting people where we are, and yet we rarely actually do. We think we do, but we don't. And so let's just break down really simply two things that you just said that are very much about meeting people where they are. Number one, it's just physically, right? Sitting down, eye contact, open posture, open gesture, so that you use the word looming, right? So that we're not looming. We're equal. We're on the same level. We're just talking as two humans. Yes, you're still wearing the white coat or the stethoscope. You still have the chart. You're still the clinician, but you're just two people talking. And that goes a heck of a long way in meeting people where they are. And then secondly, and I love that you went there, and the examples you gave are great. Meeting people where they are emotionally is something that we need to think about very powerfully and very purposefully in communication. Because, as you pointed out, when there is an emotional response, you run the risk of losing everything else that you're going to do, because the emotional response can act like a wall, just a shield. It goes up, and it might be anger, it might be fear, it might be frustration, it might be sadness, whatever it is. And if you don't get through that wall, first of all, if you don't meet that wall and then get through it, anything else you do is going to be compromised in some way. And so and Todd and I talk about this a lot. It's one of the key points of our first CME module that we have, the importance of active listening and working through the emotional response. Because no matter what that emotional response is based on, right? Sometimes it's based on false narratives. Sometimes it's based on just information that is not true. But that doesn't invalidate the reality of the emotional response, right? And then when it is on things that are very, very powerful, as the kinds of discussions that you were using as examples, I feel like it's stuff that we pay lip service to sometimes when we talk about it in healthcare, but we really need to think about it in ways that are not intellectual, in ways that are not purely data-driven or clinical. It's very much physical, emotional kinds of responses. And I think those are two big lessons to take from the things that you just said.
I think we can all reflect on times, where you're having a meeting with people, and you can look around a table, and it's really easy to tell who's not connected to the purpose of what's going on. And sometimes that can be disconnection, and phones are great for that. But everyone knows immediately that person is really pissed off about what's going on. And you can pick them out, because you don't need only the smallest modicum of human emotional intelligence to recognize the guy with his arms folded and the look on his face like his next move is murder, may not be buying into the program of what we're talking about. And so, we all have these tools. I think sometimes the residents will be like, oh, this will be really hard. And I'm like, no, you do this every day.
Yes,
you do it every day in human interactions, and you're doing it constantly. And just reflect on a family member or a loved one where you walk in and say, what is going on? And they haven't said a word to you.
You just know it. You can read it, and you also do it unconsciously, right?
Mm-hmm.
You aren't thinking about it when you enter the room. Now I must analyze why my partner looks angry. You just automatically dig into it. Also, one of the things I would always tell my students that a lot of communication is particularly in professional settings, is making the unconscious conscious. It's giving yourself permission to transfer the things that you do naturally, instinctively, instinctually with your friends and your family members, and bringing those same sorts of reaction, that same sort of emotional and communication intelligence to your professional setting.
Yeah. I mean, Todd, you've had this experience in the room. If you ignore those emotions in front of you and you ignore those reactions, that visit is often over. Because if you just ignore the elephant in the room, which is the clear reaction to what you've been doing with that patient or parent, I will often say to residents that you can say, thank you so much to someone. But if you've lost them in the room, what they're going to hear is, oh, thank you so much. And
Yes.
those are the same words. But when they cross over the midline between people, if the other person has decided I am no longer receptive because I'm so emotional now, and you clearly are not going to acknowledge it, then you're just going to hear, thank you so much. Thank you so much when you hear that. And so I'll often say your intent only gets halfway between you and the other person. They're going to really interpret what you say within where they are right at that moment. So you really need, if you want to get good information across, or if you want to ally with them, they don't want to vaccinate their child, and they've got a lot of information about it. You're going to need to put them in a place where they're going to hear you. And a lot of this is about getting them there where you have a chance to communicate and you have a chance to really ally with them.
Yeah. I mean, there was a reason they called me Dr. Slow Lynn, because I really did actually like to talk,
Can confirm,
and emote, and find out what the pet was thinking that week. Also, it was yes, but this is an important point though around timing and communication, and just saying something like the thanks so much and getting out the door. But I think a lot of because communication is not integral to healthcare, though it should be. It's just as important, if not more important, than your stethoscope and otoscope out there. But because it's not, I think the perception of residents and even attendings, when you talk about how you might want to go in there and approach the conversation, they're like, it's just more, it's more. And I'm like, what if I could tell you that if you were a better communicator, particularly those that have recurring visits like in primary care, that you can actually make subsequent visits faster, more efficient, and more effective. And if you are seeing a patient that's hospitalized for a week and you're on service that week, you're going to see them 7 times, or more. What if I could tell you, I can give you a tool set that makes each day better, because now you're connecting in a more powerful way. It builds trust that allows us to get to a better place to explain things we want to. It allows and empowers the patient to share more, because now they trust you and they realize, oh, you're not railroading me or steamboating me or demeaning me or judging me. You're kind of, I'm not accepting all your recommendations, but you're not mad at me. You keep asking me more about why am I thinking that way, or where did I hear that? And then you're kind of, as I like to say, figuratively getting on the same side of the table as them. Like, look, we're all behind getting Joey to a better place. We want him healthy. We want him out of this hospital. And it sounds like you're pulling for Joey and I'm pulling for Joey, but I'm coming from a little bit of a different place than you are. But you're not mean or picking on me, and you're intriguing me a little bit, because that's not where my thought process was when I started talking to you.
I don't think people recognize how long bad communication takes, because they may think in the moment, if I can be a bad communicator, it's going to get me out of this room quickly. Maybe that's true occasionally, but what it is it's going to gum up the works for everybody else behind you if you got out fast. So I've seen many of your colleagues, sadly, and you know this, you both have seen this, consuming as well as delivering healthcare. The colleague who's in the room with their hand on the doorknob the whole time, standing at the door, delivering information to a family, which you'll be shocked to hear that may give the signal to the family that person doesn't want to talk to them. And so that person gets out of the room quickly sometimes. But what happens to the next provider, the nurse who comes in, is a family that's absolutely seething. Or you're working at the front desk and that family's walking out. Can I set up a follow-up visit? Well, I don't know, because that family is, you're just passing the buck with bad communication. But a lot of the times it's going to impact you and slow you down. You put put a perfect point in there. It's an investment that just pays off over and over again,
Right.
over and over and over
Yes.
again.
Wait. And now, for everybody listening out there, and again, part of our audience.
Let me say one other thing to that, Todd. Communication is a skill like anything else. Horseback riding, swimming,
Yep.
right? It takes a while to master. And so when you're learning it and going through those iterations, then yes, it does slow you down a little bit. But once you nail it and it becomes second nature, that's when that investment kicks in. And literally every single interaction after that, you become faster. And I could not agree with you more, Andy. Good communication actually is what saves you time. The better you are as a communicator, the faster you are at anything, because what you're doing is, in the end, you're investing in understanding or acceptance. And your communication, your words are your capital, right? You want full value. You want to buy that understanding for the fewest number of words and fewest number of minutes or seconds in that room or anywhere else. The more economical and focused you are in your communication, the more economical and focused you will be in everything else that you do.
And what I hear a lot, Chad, is that we have some unbelievable communicators in our hospital, and pediatrics tends to attract them a little bit. It's no coincidence that Todd went into peds because he's a great communicator. But I think that we have the residents who are like, oh my, how am I ever going to do that? And what I will always ask them to do is, I'm like, I want you to ask, next time you're on with Dr. So-and-so, I want you to ask them if they've ever worked at improving their communication. And yes, we have the 5 tool athletes of communication, and the 3 of us know those folks. I mean, those folks whose emotional intelligence is, they can read a room unbelievably, and they have a lot of natural skill. But inevitably, if you drill down with those folks, they have learned to practice that skill too. They've worked that muscle.
Yes.
And what I'll always say to those trainees is, we are all working to get better at it. And so what they should be is a role model for you of how that constant practice and attention to it can build you to a height that you just sit back and say, wow, look at how they worked with that family. This is a buildable skill, which is why I'm so excited for what you guys are doing, because it's not about, I'm going to teach someone how to counsel in a room about a vaccine refusing family. Right. It's really building a general tool set.
Yes.
That's going to help improve you. And that's going to have overflow to lots of different places.
And I'll segue off that by saying, of course, there's a lot of news and a lot of information in the news cycle about vaccines and people talking about communicating it. But this is not just vaccine agnostic. This is therapy agnostic. This is treatment agnostic. This is quality metric agnostic. I don't care if you're trying to improve asthma, inhaled corticosteroid percentages, or blood pressure rechecks on end-stage renal disease. Like, the whole thing is about behavior change. How do you get people to change their behavior? Because what we have is a bunch of really good information, data-driven information that can lead to better health care delivery and better quality of life for our patients. I wanted to come back to one point you said that we're all working on, but I think we work on it if we do as individuals, but not so much in our health systems at a macro level. Because what I think and what I've seen, and that we also, through the AAP, through our practice, we're very focused on the business side, right? You have to be efficient and effective, and things are measured in value-based care metrics. But the lever that's often pulled by administrators when it comes to, oh, wow, quality's dropping, everything else, see more patients, more RVUs, more visits per hour, right? That's the lever, because honestly, that team, those are oftentimes business focused people. And as Al Wolf, our former CFO and now VP of Finance and Analytics, often likes to say through his analytical brain, is everything's a math problem. But the problem is that often gets solved with generate more RVUs, because if quality's dropping, I guess we're doing as well as we can. I would say, and it was funny, I relayed this story to Chad a couple of days ago. We were talking to an executive team from a health system and talking about this work, about communication. And they're like, we agree. We get it. We've been doing this. But how do you get the healthcare providers to buy in and to do it? And frankly, the way it was set up was, it was an extra thing for the healthcare provider to do. And I missed my opportunity, but I came up with it now, which was, I said to Chad, I should have said, how do you get them to use their stethoscope? And of course, I would have been met with like, what do you mean? Like, that's integral to medicine. And I would have been, aha, that's right. Just like communication should be. But nobody at the administrative level, I think, gets like, it's not a tack on, it's a redesign of healthcare and healthcare training, pharmacists, nurses, docs, PAs, MPs, midwives, that communication, that's our vision for the Trusted Messenger program. A day at which communication is integral at every level within healthcare.
Yeah, and as we've said already, there's good numbers behind it. Al Wolf likes this too for a reason, right? Because as we acknowledge, bad communication slows things down. Bad communication introduces error. Bad communication decreases quality. And standardizing communication, what do we know about standardizing things? We know that if you standardize most things in any business, and let's take healthcare out of it, let's just say we're a business.
Yep.
When you standardize processes, if you're going to standardize them with a bent towards things that work, most of the time, you're going to get better quality out of what you do. And, I do, when I have colleagues who are like, I just want to do it my way, I'm like, variation kills quality. You can vary certainly in how you do the small things here, but here's evidence about communication that's undeniable. It's high quality. You wouldn't reach for the wrong antibiotic, right? You'd reach for the right one because the evidence drives you there because that'll be better for your patients. Shouldn't it be the same with communication? I'm going to reach for the right communication because that's better for my patients. And it's better if you are just a businessman. If you are a businessman listening to this podcast, kudos to you. You have a broad palette. But if you're a businessman listening, you're going to find investment here too because that good communication pays. I mean, it pays, it helps, it improves quality, and it keeps the team together at a time where, you want to retain really good people in your organization too.
I think I saw a tear in Chad's eye as you went on that little communication riff. But yes.
There have been tears in my eyes since this podcast began, as there always are when we're talking to Andy, because he gets it and he lives it, and it's a beautiful thing. And what you both were talking about earlier, again, is so important, and it's so integral to what we're doing at TMP, which is, it is very much not about giving a man a fish to feed him for a day. It's about teaching him to fish, to feed himself and his family for the rest of his life. I think I've said this before, but I'll say it now. For those of you who don't know, I am now 17 years clean as a recovering academic. And one of the things that drove me out of academia was what I thought were people focusing on a lot of the wrong things and the wrong lessons. And one of those was this notion of, let's teach communication through a series of business cases. I don't want to anger any of my friends at Harvard. I'm not saying that business cases aren't a valuable teaching tool. However, when we focus on specific cases, and a lot of my colleagues at CMU were this way, let's teach our MBA students and our econ undergrads and our BA undergrads to deliver these 5 presentations or write these 6 documents. That's great if they go out into the real world and have to give those 5 presentations or write those 6 documents. But if they don't, they are royally screwed. So let's teach them a set of communication fundamentals. Let's fill up that toolkit, that utility belt, pick your metaphor, so that they can write any document, so they can deliver any presentation. And that's part of what we're talking about here. And you even said that, Andy, you're giving them specific examples in some of your teaching, but you're teaching them skills and mnemonics and methodologies that will serve them no matter what they face on the other side of that exam room door. And that is so incredibly powerful. And again, so incredibly empowering, back to Todd's point of, if you fill up that tool belt, and every exam room that you walk into, every situation that you face, you're going to have some skills that you can use that are going to make it easier or more efficient or more effective. You're starting to run short on time. I want to ask you about something, Andy. Todd and I talk a lot about, obviously, the trust being in individual healthcare providers, particularly ones with a longitudinal relationship. By the nature of your position at Children's Hospital, there are certainly plenty of patients and families you see for the first time with whom you do not have that longitudinal relationship. besides some of the things you talked about already, obviously, again, meeting them physically and emotionally where they are, what's some advice you have for building that trust, or at least establishing that trustworthiness when you walk into a room with patients, caregivers you've never actually seen before?
Well, the very first thing I would say about that is, to anyone who's listening, don't presume that a short encounter doesn't mean you can't build trust. And I think that sometimes folks are like, why would I use this in an emergency department visit? Or why would I use this when I'm doing a consult in the hospital?
Yep.
I don't have time. Because, I think there's this misconception that I'm going to spend 2 hours in a room to build that trust. These tools, the thing that makes them so powerful is how shovel ready they are, and they begin as you enter the room. I mean, they're really straightforward, and your clock starts with every part of the interaction. So what I try to do is be consistent. I really try to, I sit down, I introduce myself, I give a really clear explanation of what my role is, what am I there to do? Because I want the family to know who I am. And I also want them to have a very reasonable expectation of what I'm doing. I don't want them to expect me to be, doing surgery or other things like that. And part of that is protective for me too. I've got my focus, and I want to be able to be there for them. And then I really try to be very, very clear about my communication. And by being clear in communication, I mean, I am doing a lot of making sure I'm watching my language, because the death knell of most medical conversations is technical language, as it would be for anybody.
Amen. Yes.
Yeah. And all you need to do is reflect on the last time you went to the auto mechanic and they talked about the something valve and the intake this and the G2 crystal combustor a little. And you're like,
don't forget the flux capacitor.
Oh, the flux capacitor too. That's really important in my DeLorean. And so I think that you have to be really, really careful to meet people where they are linguistically. And people have varying expertise in medicine, and even someone with a lot of education can struggle to understand a medical concept, and someone with very little education can grasp it quickly. So you just got to check in. So I do a lot of checking in, and sometimes I'll even do formal teach back, which is, hey, I just talked about a pretty complex way we're going to treat your child's infection. Sometimes that could be bewildering for a family. Can you tell me what you understand my plan to be so I can make sure that information got through? A little bit of teach back just goes a long way, because sometimes the family will say, just didn't get any of it. And then I'm like, that's great. You told me. How great. Now I know I'm not going to use the words I just used because they weren't getting it through. So let's talk about, where did I lose you? So I can go back there and I can find the language that's going to get the message across. And so those are really the tips and tricks that I use, because sometimes I meet them once to relay the information, but I really want them to get the information effectively.
Why didn't I have you as my teacher? Why did I not have him as my teacher, man?
Because he's younger than you. No, okay. Feedback loops, bi-directional communication, absolutely mind-blowing stuff, Andy. Absolutely. And I'm sure you saw my reaction. We've been posting a lot about this on the TMP LinkedIn page. We're going to keep talking about it until we are almost literally as blue in the face as my shirt. Plain language, also a huge part of meeting people where they are. And again, using plain language and keeping jargon and technical terminology, the flux capacitors and the solenoids and the G2 crystals, to a minimum. It's not about condescending, and it's not about dumbing down. It's about explaining in a way that anyone can understand. There's a real simple concept that I would teach my students, and I call it the kitchen table test, which is, if what you're saying would probably sound silly or awkward or out of place being spoken across your kitchen table, you should probably be phrasing it a different way.
Yeah.
And if you just sort of put yourself there and think about that, it's a good way to not think, oh, I have to dumb this down for this patient who doesn't have my experience. It's just, hey, I'm sitting at the kitchen table talking about this illness or this treatment. How would I explain it?
I've done a lot of laboratory research in my career, and one of my most impactful folks, the guy who was my mentor for my PhD, would always say to me when we were communicating what we did, said, the Nobel Prize winning experiment that you did, that you can't explain to someone who has no clue what your research is about, is an experiment you never did, because it's sitting there and you thought it was great and I thought it was great, and no one in the world can understand it because we're bad at communicating it. And this circles back to what we started with, which is competence. You know how a family's going to know you're competent if you're really good at communicating the knowledge you have and the plan you have so that they understand it fully. That inspires a lot of confidence in families. A lot of confidence. And that it just really, they're going to think, this is someone I want to continue to come back to. And that can often be in our world where we have to have a lot of understanding for families with the information sources that they're getting things from, that's going to allow them to distinguish a little bit where the nonsense is and where the good things that you're trying to get across are. And it's going to allow them to maybe distinguish them a little bit apart from each other. And hey, that's our job.
There is so much more that we have to dig into with you, which is why you will be as we, Chad said, the Robert Klein of this show.
You know what, as I said, one of the nicest things Chad ever said about me, and he says nice things sometimes, so it's good.
I say many nice things about you. I do. But yes, as usual, Todd and I, well, all three of us, but as usual, Todd and I are on the same page, because I was sitting here thinking, what a bummer. It's time for us to wrap up this episode. But don't worry, we'll have Andy back multiple times.
I want to do power of narrative with him next time. I want to do power of narrative because I love you have so many good phrases and little mini stories to describe. The man is a Lyme disease specialist, for those of you that don't know out there, and to hear him talk about that in a way that is kitchen table approved. Oh my God.
Exactly. Yes. Power of narrative and analogy and metaphor and ways to make the unfamiliar familiar. Yes. Andy is
pop
an
culture
absolute
usage.
Genius in that. Yes. And we also want to pop culture. We also want to have an episode devoted purely to horror movies as well. It'll be a bottle episode. Don't worry. But Andy and I are going to have to cover
I will show up whenever. I will show up for that whenever. Yeah.
Thank you. Thank you very much, Dr. Andy Nowalk. I'll let Chad take us out. But as always, thank you. Thank you.
No, thank you for the invitation. Thanks for letting me shout out some of my teachers, because I truly stand on the shoulders of giants. I got to where I am at because I had folks who were amazing communicators that I've learned with, including you two. So absolutely true.
Thank you. And, I love that, Andy. And in fact, I think you have just launched a new regular feature on this show. I'm going to start asking every single guest to shout out some great teachers they had, particularly in communication. And I will do the same starting next week. But I love that you went there, and thank you for taking us along for the ride. Dr. Andy Nowalk, such a pleasure as always. He's one of our absolute favorite guests. For my colleague, Dr. Todd Willin, I am Chad Herman, and we are the Trusted Messenger podcast, where we are talking to incredible clinicians and communicators just like Andy Nowalk, so that we can figure out how we can all do better and serve our patients, our families, our communities, and public health in general. That's why we're here, and that's why we will be here next week. Thanks for joining us. We'll see you then.